Good evening, everyone, both to the respected panelists and those joining us online. My name is Dr. Urvashi Khan, and I am honored to present this intriguing and tragic case titled Silent Tear Unmasking Aortic Dissection in a Young Female with Epigastric Pain. This is a case that challenges our clinical instinct, showcases the limitations of routine diagnostic thinking, and underlines the importance of vigilance, especially in young patients with chronic illnesses like CKD and uncontrolled hypertension. Let me walk you through the patient's journey. A 27-year-old female from Delhi with a known history of poorly controlled hypertension for 5 years presented with elevated serum creatinine levels, blood pressure at presentation 180 by 100, admitted and carried out workup for hypertension and advanced azotemia. Her lab investigation showed a blood urea of 169, serum creatinine of 13, phosphorus of 10.23, urine protein 3 plus, hemoglobin of 6.9, and on fundus examination, grade 2 hypertension retinopathy. She was initiated on hemodialysis via right double lumen internal jugular catheter and was advised to continue thrice weekly hemodialysis. Her BP was controlled on 130/90 with antihypertensives including amlodipine, metoprolol, furosemide, and clonidine. Hemodialysis discontinued by the patient after 2 sessions, no dialysis undertaken for subsequent 2 weeks. She was readmitted just 15 days later with complaints of epigastric pain, vomiting, and headache. Blood pressure on admission was 200 by 100. Her ultrasound abdomen was done, which showed bilateral shrunken kidney with the presence of bilateral pleural effusion and mild ascites. Symptoms attributed to uremic syndrome, urgent hemodialysis was initiated. At this point, despite hemodialysis, her pain persisted, exacerbated postprandially and post-dialysis. Serum amylase and lipase was done to rule out pancreatitis, which was normal. Gastroenterology consultation obtained, advised upper GI endoscopy. Endoscopy findings were erosive pangastritis, which again attributed towards uremia. She was managed by intensive hemodialysis, sometimes consequent days, sometimes otherwise on alternate days, considering uremic gastritis and fluid overload. 2D echo was done to rule out any features of heart failure, and the report was suggestive of mild MR with EF of 55%. Blood pressure at discharge was 120 by 70 on a regimen of 5 antihypertensive agents, including amlodipine, metoprolol, furosemide, clonidine, and minoxidil. After 3 days of discharge, she again presented with right hypochondriac pain, vomiting, and accelerated hypertension with BP of 200 by 120. History of non-compliance was again there of having missed 1 session post-discharge. Her non-compliance soon became a recurring theme in her care, and primary symptom was uremic symptom, given the history of chronic kidney disease and prior admissions. Persistent right abdominal pain with tenderness noted on examination. 2D echocardiography performed, inconclusive findings were there. On evaluation of clinical suspicion and further workup, despite regular hemodialysis, the patient continued to experience worsening abdominal pain, particularly during and after dialysis. Initially attributed to uremia, followed by concerns of fluid overload. Given the refractory nature of pain, a buprenorphine patch was trialed for symptomatic relief. The partial response to opioid analgesia raised suspicion of vascular pathology, either thoracic or abdominal aortic dissection. At this point, something didn't add up. The labs were corrected, the dialysis was restarted, but the pain, it did not go away. So we took a step back and asked ourselves, are we missing something? And that's when we decided a CT aortogram was planned. And this is what we found. CT aortogram performed showed dissection with dilatation involving celiac trunk extending to common hepatic artery, right and left hepatic artery, splenic artery, and gastroduodenal artery. Evidence of dissection extending from the origin of right common iliac artery and extending to external iliac artery and internal iliac artery. On the left side, dissection originating before the bifurcation of left common iliac artery and extending to external iliac artery and internal iliac artery. There was bilateral pleural effusion and mild ascites. This is the CT aortogram that revealed the full extent of the vascular involvement. This was not an isolated vascular event, but a multi-vessel dissection, which was spontaneous in onset in a patient with no connective tissue disorder, no trauma, no pregnancy, and no recent intervention. This explained her persistent abdominal pain, her lack of response to dialysis, and why earlier investigations didn't yield any answers. It was vascular from the start. We could see there are celiac trunk dissection, left common iliac artery dissection, splenic artery dissection, right common iliac artery dissection, and right hepatic artery dissection. So she was managed under multidisciplinary management. Cardiology and CTVS team were involved. CTVS team recommended strict BP control with a target of less than 120/90. Hemodialysis was performed, after which BP stabilized at 100/60 millimeter of mercury with NTG infusion. Significant reduction in pain was observed post BP stabilization. 3 hours post hemodialysis, the patient developed generalized tonic-clonic seizure, acute hemodynamic instability, bradycardia progressing to cardiopulmonary arrest. Despite immediate resuscitation efforts, the patient could not be revived. So, discussion. To place this case in context, I'd like to begin with what the literature says about spontaneous celiac artery dissection. This is a rare vascular pathology as shown in the literature, with only 19 isolated cases of spontaneous celiac artery dissection described. Even more rare is when this occurs with other artery dissections but without abdominal aortic involvement, which is exactly what we saw in our patient. Historically, celiac artery dissection was only diagnosed post-mortem, but today advanced imaging like the CT aortogram helped us make an early diagnosis, but it was catastrophic for the patient. Spontaneous celiac artery dissection is typically iatrogenic or secondary to trauma, connective tissue disorders like Marfan or Ehlers-Danlos syndrome, cystic medial degeneration, periarterial inflammation, fibromuscular dysplasia, infectious causes like syphilis, fungal infection, vasculitis, polyarteritis nodosa, atherosclerosis, or physiological states such as pregnancy.